What we're talking about this afternoon is exclusively unruptured aneurysms.
People with an unruptured aneurysm have never had a rupture, have a tough decision.
You're never more safe than when you know you have one. And I still remember them telling me that.
Welcome everyone to our third annual webinar of 2023, Living with a Brain Aneurysm Diagnosis and the Struggles of Watching and Waiting. And we have a great panel this evening, or late afternoon, I should say. Dr. Christopher Ogilvy of BIDMC, Beth Israel Deaconess Medical Center in Boston, Massachusetts. He's a professor and a neurosurgeon at Harvard Medical School and one of the founders of the Brain Aneurysm Foundation. We have nurse practitioner Deidre Buckley, also of BIDMC and also a founder of the Brain Aneurysm Foundation. And then we have Thomas Tinlin, survivor and chairman of the board of the Brain Aneurysm Foundation. So with that being said, we're going to get right into it. So question one, Dr. Ogilvy, can you tell us how often the decision is made to not treat a brain aneurysm and what plays into that decision?
Well, this is a very timely question, especially for the research that we've been doing, looking at treatment of aneurysms over the last 30 years, taking what's published in the literature and culling out the size of aneurysm and age of patient and that type of thing for unruptured aneurysms. So what we're talking about this afternoon is exclusively unruptured aneurysms. So once they rupture, of course, we repair them right away. We published a study a few years ago, where we looked at our results from treating unruptured aneurysms, both endovascular and surgical. And there was about 650 patients in that study. And we made the comment and went back and looked. And during the same interval of time, which was 4 years, there were 900 patients that we saw that we did not treat. So the question is, why didn't you treat these people? Well, this is something we talk about every week at our neurovascular conference. And it hinges on a number of factors. And as many of the listeners know, one factor which drives us is size of aneurysm. Now, when an aneurysm is very small, the risk of rupture is so low, it's tough to justify treatment, meaning taking any risk, even if it's 2% or 2% or 2.5%, 3% risk, balanced against the risk of the aneurysm rupturing, which is exceedingly low. Other things that play into that, and we're getting better stratification of this information, but other things that play into that are size of aneurysm. In addition to size of aneurysm, is location of aneurysm, age of patient. So the way the age of patient factors into this is the longevity and the number of years they have to live with that aneurysm. So if something has a risk of rupture of 1% a year, that means the next year there's a 99% chance nothing will happen. So if you're 85, the number of years I, as a treating physician, have to worry about are lower. If you're 35, there's a lot of years at risk, and that 1 or 2% per year does add up over time. So that's one of the things that factors heavily into our decision making, especially if we're dealing with a younger individual. And I should get right on the table by size. Typically what people talk about is above 6 or 7 millimeters as a size that we routinely treat. And below that, it enters into the gray area, really, is sort of the 3 to 5 millimeter aneurysm. That's where the discussions are had. Now, let's see, so it's size, age of patient, location of aneurysm has an impact because some locations are more likely to hemorrhage than others. And also appearance of the aneurysm, the shape. Is it a nice round bubble that's small? Those have a lower risk of rupture. One large study several years ago demonstrated that if it's irregular in shape, that can play into the decision to treat it. One thing that we have been finding, and a paper has just been accepted for publication that we wrote, is that over the last 30 years, the size of aneurysms, unruptured aneurysms being treated, has been steadily decreasing. So 30 years ago, 6, 7 millimeter aneurysms were being treated. Now 4, 5, 3 millimeter aneurysms are being treated. And there is some justification for that because what has happened in the treatment world is that the risks of treatment, using endovascular and carefully selected surgical techniques are lower. So if a risk is lower, then that balance between risk and benefit can change in a way that treatment can be recommended. The other thing I'll mention about location is cavernous sinus aneurysms. The cavernous sinus is behind your eye. The carotid artery runs through this venous lake before it gets into the head. And it turns out the risk of an aneurysm rupturing when they occur in that location is exceedingly low. So that real consideration has to be given as to whether or not one treats an aneurysm in that location. And then the other thing that factors into the statement you made when we were starting is that, you know, watching and waiting, who's making the recommendation to watch and wait? Is this a general physician who has a casual knowledge of the aneurysm literature? Is this a stroke or vascular neurologist who really knows the granularity I've just been talking about, kind of chapter and verse, kind of millimeter by millimeter, what your risk is? And we're getting better and better at estimating that. That is, what happens if we do nothing? That's the big question. And that's balanced against a treatment risk. So similarly, if an aneurysm, even if it's a little larger, is in a location and has a treatment strategy which carries with it an 8 to 10% risk of a stroke or a problem, and a 2% or 4% risk of hemorrhage over the next 10 years, then we sometimes opt for continued observation. So it really is case by case at the moment. Although we do use all the information we have to make that recommendation.
Thank you, Dr. Ogilvy. Deidre, we're going to hop over to you, and it's somewhat related. So you've been working with patients and their families for over 35 years and have seen changes in treatments and the approach to treating or watching and waiting. What impact do you see in the patients and families in the watch and wait situation, and how often is it part of a conversation in the support groups you're on? And what are patients' greatest concerns with not being treated immediately?
Okay, thanks, Christine. Thank you, Lynn. And it's so great to see everyone here today. I'm really happy you're all here. We have a monthly support group meeting we do via Zoom here in Boston. And I highly recommend a support group. I've been doing it now for about 35 years. And over this span of time, yes, technology has certainly changed things and how we treat aneurysms. So our discussions at support group tend to be more hemorrhage patients, recovery, timing of going back to work. But we do have, a handful of people, probably every support group meeting, that have an unruptured aneurysm, that have never ruptured before. And I try to make that decision. And I've always said for years that the people with an unruptured aneurysm have never had a rupture, do not have a family member have ruptured, have a tough decision. And I really advocate you going to a center where the doctor has knowledge of, all the literature, et cetera. I mean, Dr. Ogilvy mentioned, who you're talking to. You're talking to your primary care doctor, you're talking to, a neurosurgeon, who does treatment. So I think the key is it's patients' angst over, treatment. It's, horrible for them. And we've been at support group meetings, where a majority of our patients are ruptured. And if they had an opportunity to get it treated, hands down, 100%, they would get it treated. And again, the balance, as Dr. Ogilvy had mentioned, is treatment risk less than, treating it. So, I think it's a very tough decision. I think we are trying to raise awareness in terms of aneurysms, letting people know about the disease. And, again, over 35 years, I find that we've made a dent, but there's still, every week, there's someone that has been seen, either locally by a primary care doctor. We just recently had a lady who was seen, works at another medical facility, was told to watch and wait, and it was a 6 millimeter aneurysm. And her mom just died, 2 months ago. So I think I have been exposed to these smaller aneurysms that rupture. I think if we could do it safely to treat aneurysms, 100%. You know, I think that's my feelings. I know it's the feelings of many of the patients who have undergone a rupture. So I think it's a tough decision, but I think number one, you really have to go to a facility that treats aneurysms and not someone who does, 50 a year. I mean, you have to go to a place that treats many of them. So it's tough. It's tough.
Deidre is absolutely correct. Pardon me for jumping in. I'm going to finish what I was starting to say. I apologize because I am going to have to go do an acute stroke, take care of a patient with an acute stroke in about 20 minutes. But I wanted to finish up this business of size. It's very confusing because if you look at the literature on ruptured aneurysms, about 80% of them are less than 10 millimeters, and a full 60% are less than 5. So we can treat an aneurysm that's ruptured out of the emergency room and run up to the office and see someone and pull up the films, and the same aneurysm can be looking at us. It's 3 or 4 millimeters. So, and this data has not really been explained. There's no statistician or biostatistician who can explain it. And this is something that enters into the decision-making. Similarly, people with several aneurysms, certainly if one ruptured, we're much more inclined to fix the others, almost regardless of size. And sometimes you ask, oh, someone has 2 aneurysms, is the risk of 2 4 millimeter aneurysms, is the risk of rupture double that of someone with 1 4 millimeter aneurysm? And that data is not known. It seems like it's more likely, but it's not double the risk that we have looked at, and it does not seem to be the case. And I'm just going to jump in, Christine, if it's okay, and address this issue of artificial intelligence, because
I was going to ask you to do that.
This is coming down the pike. So with artificial intelligence, we now have programs set up that anywhere in our healthcare system, of the healthcare system I work in, when a scan is done, artificial intelligence, the computer reads the scan and lets the neurosurgeon or neurologist know immediately there's an aneurysm, regardless of size. Now, then it's left to them to know what to deal with it. Call the patient, tell them about it, talk to them about it, which often requires a good 45-minute, or hour talk, regardless of size, sometimes, even if you're not going to treat it. However, artificial intelligence, I think, is going to be important here, because the other thing we can do is we're getting not only just when an aneurysm is a bubble, the radiologist puts a cursor on it and gets a size. But with artificial intelligence, we're going to be able to get a volume of the aneurysm and know if it's changing in shape, and it's going to be much more exact than what we've had in the past. So we may have better answers here. And if we do get a follow-up scan in a year, there may be changes that the human being couldn't see, but the computer can, and that may make our recommendation to treat someone a little stronger, and all of us feel a little more justified. Certainly, people have a smaller aneurysm. We say, look, really, the risk of rupture is low. Go out and, do your life, exercise, normal physical activity, social activity, sexual activity, whatever you want to do day to day. But we can't guarantee that aneurysm won't rupture, but it's, statistically very unlikely is the way we place it. But it is anxiety, and often discussions about not treating an aneurysm, as Deidre knows, can take way more time than a discussion of treating an aneurysm. And you sometimes have that discussion every 6 months to a year, just to reassure people that, yes, we're in the same position. Of course, everyone feels better after a year if you get another scan and it hasn't changed. If it does get bigger, that's another thing that tends to push people to treat an aneurysm that's smaller, is growth on a scan. The data for that isn't even ironclad, but it's very suggestive that if an aneurysm is growing, that's something we would very seriously think about fixing.
So Dr. Ogilvy, do you think AI will be a good educational tool for the patients and family, just to be more visual and more regular, better way for them to see and understand and track?
I think so. And I think not only for patients and their families, but physicians, actually. And the way it's going, some of these artificial intelligence programs not only do the scan, but then spit out a recommendation of when to get your next scan. And we've done a lot of work with cost effectiveness of screening, how often to screen. It's usually at the minimum of 1 year for a lot of people. And some aneurysms you can space out even longer.
And just one more thing, can you go back and say again, because heard you say it even in DC last week. So with the AI, how does it work if someone gets a scan? Who gets that beep on their phone? You know,
It can come right to the neurosurgeon, comes right to their cell phone with a picture of the aneurysm. And no neurologist has seen the patient, no radiologist has seen the films, no primary care physician. It goes right to the treating, the physicians who manage aneurysms.
But I think they get the scan done for another reason.
Right.
So
This is if
exactly.
they're getting their scan,
Incidental,
even if it's
yeah.
being done for an aneurysm, you
Right.
get the information,
Right.
but they're usually getting the scan for some
Right.
other reason. They got hit in the head or it's incidental. And these turn up as we call incidental aneurysms. So if they're found incidentally, it's thought that their natural history, that is the risk of them bleeding, is actually lower than if they're having symptoms. If someone's having symptoms from an unruptured aneurysm, that is something that does push us to tend to treat it.
okay, thank you. And if you have to leave, that's great. I appreciate you being on and sharing this, but you know, if you have time to hang in there, that's great as well.
Thank
But
you
for now-
so much. I'm actually going to step off. I'm dealing with sort of an urgent situation, but I really thank you for having this webinar. And I know Tom is very well versed, as is Deidre, in a lot of what I've said. So thanks very much.
All right, thank you, Dr. Ogilvy. All right, Thomas Tinlin. It's your time now. So Tom, it'd be great if you could share a bit about your brain aneurysm journey and the challenges you and your family faced regarding particularly your second brain aneurysm.
Of course. Hi, everybody. So first of all, welcome. This is great. As Dr. Ogilvy said, it's so important. And it's funny, I'm looking at the chat and, you know, I see somebody from Austin, somebody from Greenland, somebody from the Lakes region, New Hampshire, and literally a woman who lives like a block away from me. What are the odds of that, right? It's just crazy what unites us. So a little bit about my story. So, you know, I'm coming up on my 6-year anniversary at the end of April of my aneurysm rupture. I was a classic case of misdiagnosis. I went to my primary care physician, worst headache of my life, sudden onset, localized behind my eye. When I'd bend over to tie my shoe or something, the pain was just unbearable. My primary care doctor at the time, no longer, was new to me. And he said, well, it sounds like stress. And at the time I had a high level, very stressful government job. And I assured this person that, you know, no, I'm familiar with stress and this isn't it. And I told him that the pain is so bad, I cannot sleep. And when I fall asleep, it wakes me up. So he gave me a sleeping pill. And then he gave me an anti-inflammatory. He said, let's try this for a week and we'll see how you do. If it gets worse, call us. So I took the prescription, the medication is prescribed. In that last day, I took my last morning dose of this anti-inflammatory and my aneurysm ruptured that day. It was a Sunday. And I was funny because I said to my wife, I can't wait to call this person tomorrow and tell them, listen, we got to do something here. You have to, literally, I said, you have to get me scanned, but he was reluctant to do so. And what I've learned since then is I was textbook, right? Textbook symptomatic. And for those of you who have suffered a rupture, you know the drill, right? I mean, it was significant, and they told me I was most likely not going to make it through the night. And if I did, that they would try to do something for me the following day. Obviously, I did make it through the night, and they did a coiling of the ruptured aneurysm the following day, and that began my journey. You know, 2 weeks in ICU, and not out of the woods for 30 days, the things that we live with, and during that time of the rupture, they incidental finding, they found a second unruptured aneurysm, which at the time they deemed inoperable because of its location. It was what they call bifurcated. So you have your arteries here. It was this bubble right smack in the middle of them. So they really weren't sure what they could do with it. And at the time, there was nothing they could do with it. So as Dr. Ogilvy said, I'm walking around with this unruptured aneurysm, having just almost died from a rupture. And that's not a great place to be, right? I mean, the fear, the doubt, the insecurity, and, trying to put on that brave face for, my wife, our families, my children. And, but I knew that I had this time bomb in my head, and, it almost got me once, and now it might have an opportunity to do it again. One thing, that I was blessed with was, the advancements of research. And, I went for my checkup. So Dr. Ogilvy, as he had done on so many times, I was expecting to hear, "Oh, you're all set. It hasn't grown. It hasn't moved, and see you later." So my wife and I were taking a vacation the next day, and something about Dr. Ogilvy, he's very animated and full life. I just adore him. And he comes in the door and he just looked different. And he says, "So we need to talk." And I looked at her like, "Oh boy, here we go." And he told me that, we have something that we can do, right? And we want to go in and we want to take care of this aneurysm and get it. And again, I was walking around with it for 5 years up to that point, and I really that was exciting and scary for me at the same time. I think for those of us who have had a rupture, it's all about just help me live, right? I don't want to die. I have more to do and all that kind of that fear, right? There's nothing we wouldn't do. But when they tell you you're going to go in for it, that can be nerve wracking, right? So and I knew the surgery was coming, and so on November 1st, it was angio, this tiny little red dot in my wrist, and they went up and he put a stent in there that allowed the blood to flow freely into the areas that it should have been and bypass the aneurysm. And I was out the next day, and I'm the world's worst patient, right? Because I was like, I want to go home, I want to go home, I want to go home. And finally he comes in to follow him on. He said, "Before you ask, you can go home today." Where ironically, five or so years prior, when I had my rupture, I was the same thing. I just wanted to go home. And I don't know about you all who are rupture survivors, when they said, "All right, you can go home," I didn't want to go. Right. When I was in the hospital, when I was in ICU, I felt safe. Right. And I knew I was cared for. And every time when I went home, every time I sneezed, I was like, I mean, you guys know what it is, right? I was like, coil's gonna come flying out of my nostrils. Like, what's gonna happen here? Everything you do is concerning. So, but for me and my family, this journey, and I think for probably most of us, right, it's a team sport. And when your children see you at your worst and they're not sure if you're going to be there for them and be all those things that a parent should be. My kids were 14 and 16 at the time, and I mean, that look of fear on your child's face. My wife, it was heartbreaking enough, but to see that their whole world became unstable, everything that they counted on, the earth beneath their feet all of a sudden was sand, right? And it took a lot to get over that. And we were blessed by being in Boston, respectfully. And Beth Israel just happened to have the Brain Aneurysm Institute, and I got the wraparound services that I get frustrated when I hear the stories of other survivors who don't have it. So I had the neurosurgeon who saved my life. I had the neurologist who continues to check on me and do certain tests to make sure that everything is going the right way. I had physical therapy. I had mental health therapy, which if you are a survivor, or if you're walking around with an aneurysm and you haven't talked to anybody about it, there is no shame in that. I strongly urge you to do it. Because again, it's, we're trying to put this brave face on for everybody and coming to grips with what had happened. And, was terrific. It really was. And, and now I am very active in the Brain Aneurysm Foundation, of which, Dee Dee and Dr. Ogilvy founded. I sit as the chairman. I work with, Lynn and Christine, and, the whole idea is to try to spread that awareness, right? I mean, if my doctor just said, something, you have never, ever presented this way before, so we're going to go get you a scan, I would have went in, they would have found it, they would have coiled it, and I would have been home in 24 hours. Unfortunately, I lost my career, and trust me, I have a job I love, but I couldn't do what I had done previously the way I felt it needed to be done. And we, again, as a family, we walked through all of that fear and uncertainty. And I like to think it definitely changed me. Sometimes I think for the better, and sometimes I still get angry, and why me? But then I look, and we don't compare, right? Your aneurysm story is the worst story in the history of aneurysms because it's your story. But I do know how lucky I am, and I'm just blessed, and it's so good to be here and to continue to share this in hopes that maybe it might help somebody. So.
Thanks, Tom. And just one more thing. I mean, you've had the two experiences. So what so many people we hear about is just that angst. So what was it like for you for 5 years thinking about the second one, and then you wake up with a pin prick in your hand? I mean, the difference in that 5 years of living to having that unruptured, treated, and then going forward, like what was that change in your,
I mean,
from one day to the next?
No, I appreciate that. So the 5 years, I mean, I'll be honest, every night when my house was quiet and dark, I'd think about it. And I'd think, like, is this the night or is this the day? Because as Dr. Ogilvy kind of insinuated, right? Small aneurysms burst too. And, the location matters. It's, I mean, it's really, it's unsettling to say the least. And there are some days that it's just all I would think about. Post-treatment, a sense of just profound relief, gratitude. And it's weird in a way, I still can't believe it, right? It became part of my identity a little bit. And now that it's no longer there, I'm just so grateful to everybody who worked so hard to come up with a way to cure this for me and save my life. And what I've come to learn is that, aneurysms are treatable, right? But you can't treat what you don't know you have. And so, more people should wake up and feel like I did the day after. I look at this little red dot on my wrist and I'm like, wow. First of all, I don't know why they take the long way, but that's okay. But it's just amazing. And, and more people look at, the more awareness we raise, the more lives we save. It's as simple as that for me. So I hope that helps, Christine.
Yeah, no, thanks, Tom. All right, so Dee Dee, we're going to circle back a little bit to what we started talking with Dr. Ogilvy about. And I know some of your biggest concerns with this disease is obviously support and education. So do you feel there needs to be better education or communication for the patients who are told to have their aneurysm monitored? And do you feel that AI will be a part in that going forward?
Yeah, thanks, Christine. So people that we see and we say, we'd wait, which is honestly very few aneurysms these days that we would wait to treat. So they'd either be wait and treat because they're intracavernous, like Dr. Ogilvy mentioned. Those aneurysms we don't worry about. So I think, first of all, you have to find a doctor that you're comfortable with and you trust. And I think, you have to have that trust. And as Tom referenced the 5-year period where he had that unruptured one, I'm not desensitized to the emotions that people may experience, but honestly, you have to trust that we know what we're doing and we don't think will rupture. In my 35, almost 40 years of working with patients, I really trust Dr. Ogilvy. I've worked with him for many years. And I think, they do know the disease and which aneurysms rupture or do not. I think artificial intelligence is going to be great in terms of detection. So we detect them, and then what? That goes, the doctors that treat aneurysms then find out about it. I think it's going to be critical, as you mentioned, Christine, the education piece. So I think you're going to need to find a doctor who's going to sit down and meet with you and discuss what this means. I think we'll be finding a lot more aneurysms that we wouldn't necessarily treat, but may treat. And I think that's actually a good thing. One of the things that we talk about within the foundation is that there's probably a lot more ruptures that we don't know about that are from aneurysms because, we don't do autopsies. So I think the rupture rate perhaps could be higher. So if we're able to detect them and able to treat patients safely, I think that's great. I think one of the other things with artificial intelligence we're hoping for is that it will help us predict rupture rate. So when we meet with a patient, there's certain aneurysms at different locations of the brain. Most of the aneurysms we deal with, as many of you know, is within the circle of Willis. And, there's certain aneurysms that probably are a higher risk of rupture than others. And, that is certainly we've disclosed to patients and discussed that with them. But if we can, I think one of the main things is with aneurysms, you don't know when they rupture. With aneurysms in, like, say, the aorta, when they get to 7 millimeters, you should treat. We know that these small aneurysms do rupture. So I think, again, if we're able to treat, we tend to be very aggressive here. We will, if we can do it safely. So I think that's really important. In terms of education, I think it's, these groups are great. I think the support groups are great. I encourage them highly. I encourage you all to tell your stories, because so many people don't know about brain aneurysms. I know the foundation went to Washington, D.C. Many people who they met with don't know that our president had 2 aneurysms. And I think, that needs to be highlighted, and you need to talk about it. And if you don't talk about it, you don't know about it. So I think these groups are great. These webinars that the foundation does monthly are fantastic. And I encourage you all, to talk to each other. I mean, within this group, I know within our support group, patients talk offline, but every month we get together. It's really important to talk about it, to talk about your feelings. And for those who have not been treated, to talk to those who have ruptured. And I think, in a heartbeat, they would want to be treated if we can do it safely. And, it's a blessing. I've seen the technology improve over years, and where we initially, back in the 80s, we treated mostly ruptured patients. Then MRI came, CTA came. We're able to, treat people, unruptured. Then the technology came for the endovascular treatment in the late 90s. Now we're doing the pipeline. We're doing so many different stents. So I think that is, we're lucky that we live in this age and we're able to treat people pretty safely. And I think there are a lot of centers, there are experts. And I think it's, you need to go to those doctors and you need to talk to each other, so you can just get the word out.
All right, thanks, Dee. Tom, we're going to go back to you before our Q&A session. As you explained, you've had quite a journey and dealt with the aneurysms from 2 different sides. What is it that you hope for the future generations regarding screening and treatment?
Obviously, without screening, we don't know. And I think that, it would be great if, primary care physicians would think about it in terms of what it might be as opposed to what it should be, right? And the symptoms are different, as we know, right? That sudden onset, worst headache of your life. If the medical community, and unfortunately and sadly, the insurance companies were more ready to send people for a scan, obviously we would save more lives. And so I think, for us, that's really the key. So my hope is that future generations won't have to fight so hard for what I would describe as the basic diagnostic tool to figure out if a brain aneurysm exists or not. And I do think, some of the groundbreaking research, that some of us learned about in Washington, D.C., who went to advocate, there's things that are on the cutting edge, like a blood sample, right? A blood test that could determine if there are certain enzymes that may indicate the presence of an aneurysm, thereby giving the healthcare physician more leverage to order a scan. But the scan is what it's all about. Listen, if I knew that I could be in and out of the hospital in less than 24 hours and have brain surgery, I would have been all for that. So that's my hope for the future, is that folks won't be so reluctant to get their patients scanned, and there's more awareness to go along with that.
Okay, thank you, Tom. I appreciate that. Before we get into the questions, some of the things that I just wanted to touch back on is, Dee said it, and probably Dr. Ogilvy, the importance of seeking a second opinion. And we have people reach out to the foundation often about this and who to go to. And I think it's, again, who you're comfortable with, but seek those second opinions, and don't just hear from one doctor and take that as gospel. And connected to that is, and Dr. Ogilvy brought it up at the beginning, and I never even thought about it, you're diagnosed, but then watch and wait. Who is telling you to wait? And I never realized that till just in the last couple of months. We have someone, a family that lost their mom at the age of 60. This young man recently married, just starting a family, and went to his primary care and asked about getting scanned. And they just said, and again, he's young and fit. Their mother, one of the sons said, was fitter than anyone in the family. You don't have to worry about that. Don't even worry about it. But I don't even know why you're thinking about that, and completely dismissed him. And his mom is home, finally out of her rehab and she needs full home care. So again, not the right person telling him to watch and wait. And then again, another scenario of someone that we know that has been treated, found out that the friend was told, oh, just wait. And she was told by her oncologist. So again, you really have to get that right opinion. And I know there certainly are times where someone will be told to watch and wait, but I think it is critical that you're getting that information from the right source. And again, from all the calls and emails that we get here at the office, you have to advocate for yourself. Doctors who have seen you or treated you, they have to answer your questions. The nurse practitioners like Deidre field questions all the time, but particularly if someone's treated you or has looked at your scans, feel free always to go back and ask those extra questions. I mean, it's your brain, it's the one life, and you should feel empowered to ask what it is that you need to know. So with that being said, we'll get going with some of the questions that came in, and maybe Lynn will keep an eye on the chat to see if there are any new ones. But someone asked, after experiencing a rupture on one aneurysm, the second aneurysm is small and on a watch and wait approach, and they're wondering, when does that fear go away? So Deidre, or I don't know if you want to touch that, or Tom. I know it's like a hard to answer question, but still should be addressed.
So this is a quick question. I'm just wondering if this person has ever gotten a second opinion. Sometimes, how big is the second aneurysm? Did she say?
It's small. She's had an 8 millimeter, but the second one is small.
But ruptured for the 8 millimeter or not?
Had a rupture initially.
Yeah, I would get a second opinion. I mean, I think these days we treat very small aneurysms. And to Tom's point, his aneurysm we watched for a while because it was in the basilar tip area and it was a Y area. So, technology improved such that we were able to do it. But again, certain questions, I mean, if you haven't asked them now, exactly why, ask the surgeon. You live with a rupture, you had a rupture, you're living with an unruptured one. Can you please treat it? I mean, what are the circumstances not to? And again, it would be too high risk to treat, would be, for me, the only reason not to treat it. So, and again, second opinions, I encourage it if, need be.
Okay, question we get a lot, no matter the topic, is what age should your children get scanned if their parent had an aneurysm?
So we typically tell people, about 20 years old to start screening.
Dr. Ogilvy, if you're back on, feel free to jump in.
Yeah, 18 to 20, which is of course when they all feel invincible.
Yes.
But 18 to 20, and then every 10 or so years after that, through your 50s really is sort of the current recommendation. But that's for 2 or more family members who are effective. If there's one other family member, I just reviewed a paper recently, if there's one unruptured aneurysm, actually it's tough to justify getting a scan in the rest of the family. If there's one ruptured aneurysm, then family members should be screened. So a little confusing, but and in Boston, if someone's anxious about their sister had an aneurysm, we tend to screen them. Now, whether that's covered or not by health insurance is another issue. Some of the PCPs we work with are kind of savvy and say, oh, they have a headache, so we need a scan, even though the real reason is they're anxious about a familial situation. But that's the way we tend to do it. 20 years old, every 10 years after that.
Okay, here's a question. At what point after diagnosis should you be seeing, it says a neurologist, but I don't even know if that's the right doctor. So apparently if someone is diagnosed, then I guess how should they follow up and with who?
I mean, I would recommend a neurosurgeon, since they, especially, Dr. Ogilvy does both endovascular and open surgery. So I would encourage someone for sure to do a surgery because they treat these aneurysms and they can often tell you better than a neurologist, what's treatable and what is not. I mean, Dr. leaving comment.
I kind of echo that, and our neurologic colleagues are good at this. Some of them just, do more of this than others. Neurologists do a lot of things too. Some do seizure management, some do MS, some do spinal work. However, they don't often see the volume and the length of time that we follow patients. So Deidre and I have followed patients now for 30 years. And some of those were watch and wait. And after about 15 years, and they started at 60, and when they got to be 80, guess what? We all backed off, But those are the scenarios you run into. And sometimes no two of these are the same. It all has to be taken into the context of the patient, what they do, what the risks of treatment are, and then the aneurysm, what you think the risk of hemorrhage is.
Thank you. Can a person with an aneurysm live an active full life? Unruptured.
Yes.
Yeah, thanks, Tom. This is it's not, I don't think it's fair to tell someone we're not going to treat your aneurysm because it's so low risk of hemorrhage, but don't do this, or don't do activities, or don't do your kickboxing. Look, if I'm making that decision, I want them living a full active life. And that's what the statistics would tell you to do. However, some of the neurologists and other physicians involved, even in generating those statistics, are reluctant to say that for medical legal reasons, really. But really, if we're recommending that an aneurysm is so safe to leave alone, then we really feel that normal and full activity should go into it. Now, if they're a power lifter and their aneurysm is in that size of 4 to 5 millimeters, well, that factors in sometimes to the decision making, because after it's treated, we can tell them, look, go off and power lift now without worry. But those are the kind of discussions that are very granular and, really patient to patient.
Christine, can I add on to that?
Sure.
So it being both sides of the equation, the rupture and then the non, I looked at it differently. I was like, wow, isn't this a precious thing that we have, right? And I wanted to do things and see things that I might normally not have. And my life, this might sound weird, became really full really fast, and it was terrific. And I consulted my doctors to be sure, and nobody would confuse me for a power lifter, but and it was literally try it, right? And I tell you, my life just opened. And I do want to touch on one thing. Somebody direct DM'd me in the chat, and they were uncomfortable with their care that they got, and they wanted to talk to me directly on that. I give them the caveat, I'm not a doctor. So I think you're hearing some of the things here about making sure that you advocate for yourself, get a second opinion if you're uncomfortable with what you're being told. I'm always happy, and I gave you my email address. I'm always happy, but I'm going to tell you the same thing there, which is, don't take no for an answer. But yeah, live your life, keep rocking it.
Yep. All right. Thanks, Tom. Can a pregnant woman have a vaginal birth if they have an unruptured MCA aneurysm?
I get this question all the time. So first of all, why it is unruptured?
Yes.
But like by choice, have they been, and do you have any more information?
No, that's it. So apparently they must be under the watch and wait scenario.
So I mean, no OB will do a vaginal section.
Very difficult. And so what the obstetricians want us to do is write a letter that says, we guarantee absolutely nothing will happen during childbirth. Now, no one can write that letter about anything. In point of fact, statistically, the risk of an aneurysm rupturing, there are hundreds of women today delivering with an unruptured aneurysm. And in point of fact, the risk of that probably isn't higher than the rest of the population. If you look at the entire length of pregnancy with a ruptured aneurysm, it's probably a little higher. But it may be more related to earlier in the terms when the volume of blood goes up and that kind of thing. But of course, the obstetricians want a guarantee, and without that guarantee, they'll do a C-section basically. And I've tried to make the argument, gee, statistically it's not gonna, but they just say if there's any risk, we won't do it. Now, one strategy that we've with younger individuals, and again, this is in the smaller aneurysm, that's a reason sometimes to fix them. It's smaller, we repair the aneurysm, they have their pregnancy. Before they get pregnant, they find out they have it in plan. Now, if you find it during pregnancy, you have to navigate which trimester it is, is it safer to treat it in the mid-trimester? The first trimester, radiation and the dye load from angios and the work we do is significant. But in the middle and later trimesters, it's less significant. So sometimes we have treated patients in those intervals with a bigger aneurysm, get rid of it, and then they can deliver their baby, and then in vaginally or C-section. Often still the obstetricians do count them as high-risk pregnancy and do it that way.
Okay, thank you. Then someone says, doctors seem to be consistent in saying there are no symptoms with unruptured aneurysms. Is that accurate?
That's not true. And that's not, we advocate people, oftentimes there could be eye symptoms is one location in particular. It's a PCOM aneurysm. Right away if your eye is closed. But for sure, there are symptoms that we would advocate you get checked out. It could not be an aneurysm, but for sure, if you're having any type of symptom that's out of your norm, I would get checked. Okay.
Thank you for clarifying. So someone asked, how can a family best support a sibling who's been diagnosed with 2 aneurysms after their mother died from an aneurysm rupture?
Tough. I would, so is this person going to get treated, I'm hoping?
It doesn't say, but it
So I
probably,
would encourage them if they can be treated, to meet with someone like a Dr. Ogilvy in your area, and there are many, each city usually has someone to counsel you in terms of getting treatment. And I think, to be there, it's horrible. You go to these support group meetings and, I could be in tears every meeting because of these people and that have done so well. But, if you can get it treated beforehand, absolutely. I would encourage as a sibling, the person that has the aneurysm to get treatment to help them get the best care possible. Tom, I don't know if you want to add.
Yeah, I think the only thing, first of all, yes, on all of that. The only thing I would add, and I'm a big proponent of second opinions, as Deidre referred to and Dr. Ogilvy referred to. Like it's funny, you fall into these roles in your life, and I'm like everybody's aneurysm guy here, right? And people will tell me, though, this person and that person, and I say the same thing consistently. Get a second opinion and share the film and let them talk about you, because it's sometimes the best answer is just to sit and wait, right? And sometimes the answer is, yeah, we could probably help this person, but and I can't stress enough about the mental side of it as well, right? And the toll that can take on somebody. You don't want to treat them differently. Don't look at somebody like, oh my God, I might lose them in any second, right? Because it's not that. And I don't want to sound overly dramatic, but facts are power, right? Get the facts on the situation, decide whether or not to treat. And if the decision is made to wait and see, make sure that the person that you love is talking to somebody to come to grips with that, right? This isn't a death sentence.
Mm-hmm.
You're never more safe than when you have one. And I still remember them telling me that when they said, you have a second aneurysm. And I was like, oh my God. And they assured me, like, hey, you're never more safe than you are right now, because we know it, we're going to monitor it, and we're going to take care of you. And nobody lied to me. And that's exactly what they did.
Mm-hmm.
okay, so this next question is very similar, and Tom, you probably are going to be suited to give feedback here, and Deidre probably a little too. How do I make my family not stress and feel as if they aren't doing anything during the watch and wait period of diagnosis to treatment? How do we stay calm when you can't guarantee that our aneurysms won't rupture?
Yeah, no, go ahead, Deidre.
Oh, you go ahead first.
Yeah. I think, that's, well, use it to your advantage too. If you don't want to do something, say, geez, no, I'm only kidding. I think it's the more they see you. All right, I'll use myself as an example. When my family saw me living my life, going to work, taking care of my kids, being active, taking trips, flying, right, working out, and they saw me being normal, quote unquote normal, which is a word I hate, it just made it easier for them. And, there are still times when they would get concerned, usually around my anniversary. We do a golf tournament for research and this kind of thing, and it would bring up those emotions. But, I think that it's not necessarily our job to make them feel better, right? Because words are words. Just live your life and they will feel better, if that makes any sense.
And again, I think it goes back to trusting your person who's giving you advice. I mean, if they're waiting a month or 2 months before treatment, you have to really trust, we do this every single day. And that if we're telling you to wait 2 months, we're telling you because we know it's safe, not because we want you to worry. Okay.
How do you get over the fear of facing surgery again? You had it, and now they have a second aneurysm at 7 millimeters. So they're fearful of another surgery. So how do you get over that?
I mean, again, goes back to that person's individual experience. Did they do well? Was it a hemorrhage? I mean, there's a lot of factors involved there. I'm assuming they did well and that this is a second procedure that's coming up. I mean, again, you have to trust that, you have to be patient and wait. I don't think we could take away that fear. I mean, I think it's real. I mean, as Tom mentioned, I think talking to someone is huge. And I think, that should be for sure part of the care and treatment is, you should be talking to someone outside here, someone in the medical community, a therapist or something to help you get through this period of time. I think there's nothing that we could do other than you trust us as medical professionals in dealing with this all the time.
Yeah, I would just add to that. Look at it's brain surgery. Of course, it's scary, right? If you're not scared, there's something wrong with you, right? So, and that's okay.
Yeah.
But the fact that there is a plan, right? You have a plan in place with a proven success record, right? Let's not forget that intervention of an aneurysm, whether it's a coiling, a clipping, angio, craniotomy, has an enormous amount of success. In my case, the angio, right? The odds of me living were around 15% or so on my rupture. The angio was upwards of 96% success rate. So if somebody told you you could walk around with this thing and never know when it might decide today's the day, or behind door number 2, we have something that's been successful 96% of the time that will give you a long, healthy life to enjoy all the things you want to enjoy. You go to door number 2. But don't make any mistake, being scared is not abnormal, right? It's just don't let the fear paralyze you to inaction, because that's where the danger is.
And Christine, to your point with the AI, I mean, I'm hopeful in the future. I think it's going to be long after I'm gone in terms of the AI being able to determine aneurysms that are more prone to rupture. I think that's going to be a huge part of providing care to patients and waiting. Right now we're pretty certain based on experience, but I think the AI would at least give you numbers and risk factors, down the road, because they are able to predict volume and, so I think that's to come, but I think that will be huge.
Okay, thank you. How often should an unruptured aneurysm be followed? Like how often would someone go back to the doctor to get that looked at for growth and whatnot?
Again, it's patient dependent, depending on where it's located, depending on the size, depending on the age of the patient. I mean, we tend to follow people, a year out. If there's no change, so we push it out again to 2 to 3 years. And again, if it's a stable, 5 years. But then we have patients that can't live without yearly scan, and that's fine with us too. So we have to balance that patient's emotional status with what we think is right. And I think it's 1 scan a year isn't bad,
And how often should someone follow up with the scan if they have been treated with a clipping?
So, years ago, again, we didn't know. We thought you were clipped and you were done. We now know that if you continue smoking, if you have family history, if you have a history of polycystic kidney disease. There's a lot of things that come into play. Those people should be for sure screened sooner than later. And anyone, usually now, if we clip a patient, usually within 10 years, we do another angiogram to make sure it's clipped properly. You know, there's no more aneurysms.
Thank you. And someone wants to know, is there any genetic counseling for families that have significant history?
No, I mean, right now, I mean, we have a lot of researchers looking into that genetic component. You know, we know for sure we've treated many families with aneurysms. We're hoping one day we'll be able to do a blood test to see if you have that gene for the aneurysm. I think until that day comes, there won't be counseling. You know, once we know, we could do a blood test and determine if you are carrying the gene, then we can make a decision, you know, to counsel patients.
Okay, thank you. I think one other thing, someone is just saying, I wish providers coach patients and how to cope with the diagnosis and talk about the roller coaster and collect more patients, give the patients more resources. So do you find it's normal that when this diagnosis happens, I mean, you're so used to having your support group, you know, and you probably know people at other centers. I know I do, just through our medical advisory board. Not everyone, there is definitely not a unified standard of care. So, you know, how do you think that can be better addressed, that patients get better information with this diagnosis?
I mean, unfortunately, I think in this day and age of healthcare, I think you're on your own for the most part. I mean, I wish it was otherwise, but I think through the Brain Aneurysm Foundation, we provide so much education and resources, you know, and I think for people to use us as a center, we could provide that education. But, you know, I've talked to other clinicians around the country as well. I mean, it is what it is. A lot of people, they have their surgery, they're out here after brain surgery in 2 days, endovascular treatment in 1 day. So there's not even any time to talk to people to deal with this emotionally. So it's in the follow-up, and we're in Boston. I saw someone asking where Dr. Ogilvy is. You know, when we follow our patients around the country, many people don't. Once you're treated, you'll see, I had someone tell me today, this hospital across town, they see people for 1 month after their procedure, and then you're on your own. So that's, I think, becoming less available than it was even years ago. I think you really have to 100% advocate for yourself.
Okay, thank you. We're going to have one more question that Lynn is going to read from the chat.
There's
before we wrap
actually
up.
two in the,
Okay.
one says, I have a 4mm anterior communicating artery aneurysm viewed on scan. However, I have not had a cerebral angiogram. Do you routinely suggest that for more information?
Absolutely. This day and age we do, because again, that would give you information in terms of how to treat it. I mean, this is an 4mm ACOM aneurysm is something we treat here, you know, every week.
And then the next one is, once you have a pipeline repair, is that one and done, or is there a risk of a pipeline having to be replaced?
So we feel it's one and done, but again, I know this person, I know the type of aneurysm she had. It was a blister aneurysm, which is a little bit different than your regular saccular aneurysm. So this is a person that we follow more closely. So we to date, I mean, the pipeline, as you all know on this call, probably is fairly new within the last 10 years. We've never had one replaced or any issues with that. But I think, you know, in terms of follow-up, you really have to ask your surgeon. And again, the person usually who treats you, you know, what the follow-up should be. But typically pipelines, now we're telling people, we're learning more and more that after the pipeline, after usually a couple of years of follow-up, you're good.
All right, everyone. I think that's probably where we're going to wrap things up. So a big thank you to Dr. Ogilvy, to Deidre Buckley, and to Tom Tinlin for taking their time and sharing with all of us. We will have another webinar in April, but I think the key takeaways is to talk about this and share the information and educate people. So I'd certainly ask all of you to follow the foundation social media, share the information that we're posting. Again, our second annual day of engagement is going to be September 21st. And we need all of you in all your communities to find ways to participate and get information out. So we have ways for you to do that. You can email us directly or just follow again our postings on social media and sign up for our email. But a big thank you to everybody in all your different communities. Somebody from Hungary, that's pretty crazy. Stay healthy, get your second opinions, trust yourself, and just, again, like Tom said, live your life. So thank you, everyone. Have a great rest of your evening, day, whatever time it may be, and hopefully see you soon.
Thank you.
Thanks.
Bye, everyone.
Thanks, everybody.
Thank you.